All right, everybody, welcome to Case Conceptualization and Treatment Plan. Let's go ahead and dive in. First off, let's talk about case conceptualization, particularly from a social work perspective. One of the great things is the strength of social work in our ability to conceptualize a client's case from all sorts of perspectives that really strengthen our ability to diagnose and treat. We have a lot of wonderful professionals from allied fields: psychiatry, psychology, nursing, clinical mental health counseling, marriage and family therapy. But what makes social work really unique is that ability to not only sit with an individual on a micro level and work with them on their presenting symptoms and issues that they bring in individually, but then to really kind of back up the lens and look at all of the systems that would impact that individual and potentially be impacting their symptoms. So that's one of our strengths. I've mentioned that from the beginning of class, and that's why we started off with looking at the ecological lens when working with clients, is that ability to have a person sitting in front of you, but then also being able to look at the systems that they immediately interact with, more of those kind of micro level systems, such as their family, school systems, employment, religious systems, all of those things that they have immediate relationships with and interactions with. And then the mesosystems that can be those same systems, but much more independently when they're based in the community. They have their own policies and regulations that the client will eventually interact with, likely, but they're also subject to some of those policies and rules as part of those institutions. And then we have the exo and macro level systems as well, which we're talking about policy, we're talking about culture, ethnicity, societal attitudes, all of those things as well. So in conceptualizing a case, social workers really need to, one of our strengths, I would say, is that ability to look at symptoms look at the client that's sitting in front of us with particular symptoms, and then also being able to parse out and understand which of the symptoms that the systems that they're interacting with may be impacting the symptoms that they're experiencing with. So one of the things that when you're conceptualizing a case and when you're working with a client is be sure to explore the systems that they are interacting with, and not just merely how's your work going, and they say, oh, it's going okay, and then you move on. Or if they just say, oh, it's going all right, explore that with a few more open-ended questions of what is good about it, what are some of the stressors you experience there at work. Those type of questions will help kind of give you much more insight into what may be potentially a system that they didn't expect or think of that was impacting them so much. There's been times in my career where I've had clients that have told me that, their work has been somewhat stressful, and come to find out they were experiencing harassment in the workplace and forms of discrimination. And part of our treatment planning was working with them to help address some of those issues within that system that they were struggling with. It would have been really easy for me as a clinician to merely state, oh, you know what, this person's having anxiety and depression, I'm just going to treat them in my office just for that, and hope that somehow those skills of just working one-on-one will translate into them, going in and affecting the system that they're interacting with. But once it's out in the open, we can have a pretty good discussion as to what the client can begin to do to potentially remediate or resolve that issue. Maybe it is that they develop the assertiveness to go to HR and make a report, or advocate on their behalf as far as the clinician, whatever it may take. But that's part of social work, is to not just merely kind of brush over or glaze over symptoms and systems and say like, they'll figure it out with our work here in the office. Sometimes with social work, as part of our field, it is to pay attention to how that's impacting them and make a judgment as to how that factors into our treatment planning. Having a framework and modality, as I've spoken in class, is also important as you hear their descriptions of their interactions with their microsystems, the family, school, friends, employment. Depending on the modality that you're using, whether it's solution focused, whether it's motivational interviewing, cognitive behavioral, DBT, ACT therapy, so on and so forth. Maybe a trauma lens, looking at it through trauma, ACEs, adverse childhood experiences. I mean, there's hundreds and hundreds of theoretical lenses and modalities that you can use. So as you're taking in all of this information, depending on the modality that you're listening through or looking through, you're going to start to jot down certain factors that kind of filter through those particular lenses. Now, overall, as I mentioned in case conceptualization, one thing as social work we really need to look for are what are the strengths and supports, not just strengths from the individual. That's something that we should obviously be doing of who's that person sitting in front of us, but also what are the strengths and supports with the systems that they're interacting with. Are there meso-level systems such as community supports, whether it's neighbors, whether a particular cultural group, religious group, social services that are offered, whatever it may be. Are there support systems and resources that we can tap into and that the client can tap into as part of their treatment? This can be on a personal level, as I stated, a social level, and most often those strengths and supports can be integrated seamlessly into the modality that you're using. I don't think there's really any modality where you can't integrate some form of strengths-based or support into the modality as part of the treatment. And then finally, it may seem obvious, but identifying what are the stressors and the needs with the client. This can be on a personal level. This can be on an interpersonal level, how they're interacting with family, maybe peers at school, maybe with coworkers, maybe with religious leaders, maybe with their community. All of these things as social work and from a social work perspective we need to take into account when we're conceptualizing a case. Again, this is as social workers become more and more part of treatment teams. I think you see, for example, medical doctors and other, nurses and other people really depending on social workers to bring that bigger picture in that we're really good at and really experts in. Talking about the biopsychosocial assessment, we've talked about this many times in class, so just as you're conceptualizing a case, make sure that you're looking at and ruling out, or at least having them go to a physician or medical provider to rule out possible medical contributors, especially if there's anything acute. So something that's a recent onset, something that was not happening, and then all of a sudden maybe within the past couple of months or weeks, all of a sudden developed. That's an acute situation. That if it's really abrupt and something that's not within kind of the normal kind of range of changes, whether it's behavior or physical, definitely have them go visit with their medical provider and make sure that there's no medical factors that are contributing to that. Also, chronic medical conditions are things that you'll want to pay attention to and consider as far as case conceptualization. Do they have certain medical conditions that may lead to or may be contributing to mental health? And maybe not directly, but sometimes indirectly. Maybe they have chronic health issues such as diabetes or heart issues, which may cause them to have a lack of energy or difficulty with being really active, or it may impact their diet, which then impacts the way their mental health and the way they view their mental health. Maybe they're not as active as they once were because of their medical condition. So exploring both the acute as well as the chronic medical contributors and making sure they have a recent medical visit with their doctor to make sure everything's okay. Nothing's worse than as a clinical or as a provider of some sort that you're working with a client, and I call it kind of swimming upstream, where it may be something caused by a medical condition, but because you didn't refer them out for a checkup and have them explain to their medical doctor some of their symptoms that could have been resolved through a medical condition. Instead, we're trying to treat something in our office and just, again, going against the stream, going against the river, that we never really make any headway because it's based on something outside of our field. Another thing to take into consideration is medication influences. Now, that doesn't mean we need to be an expert in medication. We just need to make sure that we remember to consider that as part of the case conceptualization, because certain medications can mimic symptoms of mental health. They can also impact the physical health, which then can in turn cause them an impact on the mental health. For example, maybe they're taking a heart medication or a thyroid medication that may cause their heart to race or their blood pressure to drop, or may increase energy levels. All of those things may mimic mental health symptoms. They might be taking medications that make them feel lethargic or make them even feel nauseous or have a headache. If you're feeling nauseous all day or have a headache consistently from day to day, you're not going to probably be doing very well mentally, because that physical pain and sensation is going to be so prevalent. As I stated, you'll want to ask and learn how to ask clients about the medications that they're on and some of the side effects if they know them. If not, consult with a medical provider and ask them, could any of these medications that this client is on impact, or what are the side effects that may be contributing to some of their mental health issues? And it may be indirect impact, right? It may not be that the particular medication causes mental health, but for example, if the medication causes nausea and the client is nauseous all day, they're not going to be doing very well mentally, because nobody really likes to feel that way, right? So it's going to be that indirect impact. Then finally, physical limitations. So you'll want to, as part of conceptualizing a case, begin to understand, are there physical limitations with clients? Especially if we are trying to have them become more active or, engage in more social activities or employment activities or whatever it may be, knowing their mobility levels. Maybe they have severe back pain, or maybe they're, for example, in a wheelchair or bound, somehow homebound. All of those things we need to factor in as part of our treatment planning, so that we can know what are some of the possible limitations and what are the things that maybe in consultation with their doctor or physical therapist, of things that they can begin to work on to stretch those limitations. Let's move on to the social aspects. We've talked about relationships before in part of conceptualizing a case, making sure that you're exploring the impact of whether it's a spouse or partner, how long they've been together, breakups, separations, divorces. And one of the questions I'll kind of ask or explore is that person contributing to their well-being? Is it benefit to their life? Or is it becoming a stressor and actually contributing to mental health issues? The reason, at least I explore that, is because that may indicate different types of treatment. For example, if that relationship is becoming a bigger and much larger stressor, it may be more important to actually have them seek out relationship counseling or family counseling and intervene on a systems level than it will be for you to do individual counseling and just try and work one-on-one with that person. That particular treatment may take you much longer to make any inroads than it would if you intervene at that different level. So understanding the relationships in that individual's life, and is there a different way to intervene that may be more effective? The same goes with family. Whether it's children, parents, siblings, extended family, understanding who serves as a support system and that is helpful, and who potentially is contributing to issues with mental health, whether it's conflict, distress, anxiety, things like that. Socially, This goes along with a lot of the strengths-based approach, which is are there friends, support systems, community systems that can help serve as resources for this individual? We also, the flip side of that is to conceptualize the case. Are these things adding to the stress or distress of the individual? Are the friends that they're hanging out with, are there certain communities that they belong to that are detrimental to that person's mental health? Then education comes into play, knowing kind of, again, the level of education. Are they trying to pursue more education? Education level can also be something that we need to consider as far as when we're conceptualizing a case, what type of homework we give, what type of tasks we assign. I've had plenty of clients in my career where they've dropped out of school early on, whether it's elementary or early junior high, so asking them to read something can be very difficult for them, or to keep a journal and write. Some of them really don't know how to write much, or keeping a journal is very foreign to them, or charting things is foreign to them. So keeping track of those factors. Then I mentioned employment before in the previous ecological systems theory. Just knowing is how much does employment contribute to the distress and symptoms of the individual. There's always, and for the most part in any job, going to be stress, but is it to the point where it's now contributing so much to their distress that it's time to figure out whether or not that employment, something needs to change as far as their interaction with that. Finally, spirituality and religion. That's something always to explore, whether or not the person engages in some sort of spirituality or religion in any of its forms or formats is something that we need to understand with clients. And as the field of social work, part of being accepting and kind of multicultural and culturally competent is to find out and be curious about what drives that person, whether it's a spiritual connection or religious connection or something just broad. I've had clients talk to me about energy work and things like that. I mean, at this point, anything that you can pretty much use with a client to help serve as a strength or as a resource can be really beneficial in incorporating that into a treatment plan. And then finally, self-care and interests, hobbies, passions, talents. Those are going to be, obvious things that you'll want to include in your case conceptualization, and especially as you're, depending on your modality and framework, those can be great foundations to build on as you move forward in treatment. Now let's move on to psychological factors. Make sure that you're taking a solid family history of any sort of mental health issues or previous diagnoses. That includes personal history from that individual. Have they sought out counseling before? How long did they receive counseling? Did they have any periods of time between counseling, and how did that go? This can use a lot of solution-focused and motivational interviewing questioning to find out what worked, what didn't work. In understanding the family history and the personal history, finding out about previous treatment can be very beneficial. Again, maybe they were only in treatment for a few weeks, and finding out, what impacted that. Was it insurance and financial issues? Was it just they didn't find it effective? So all these things are things to explore when you're conceptualizing a case. Psych meds. So in the previous, early on in the sections, I mentioned medications. Specifically, you'd need to know and should explore psych meds. This is or psychotropic meds is what it's short for. You'll definitely want to understand what they're on and why they're on it. Some clients don't even know, so that's something to explore with them as well. Is they might say, well, I'm on a certain medication, and you'll ask them, well, what exactly is that for? Have they told you? And sometimes they can't even tell you what that's for. So being able to also explore and see how informed they are, or how well they've been informed by their providers. Also in psychological factors is understanding any sort of safety issues. So it's always important in conceptualizing a case, never go without exploring that person's safety issues. Are there any sort of homicidal thoughts, suicidal thoughts? What's the severity and intensity of those thoughts? Do they have a plan? Do they have an intent? Do they have the means? All of those things need to be factored in as part of a case conceptualization, especially if you're going to be presenting it or staffing it. Safety is one of those things that you definitely want to know the answer to. You don't want to staff a case and be caught off guard if the supervisor or somebody on the team says, okay, so, tell me, do they have any suicidal thoughts or are they at risk? And like I said, you never want to be kind of a deer in the headlights thinking like, oh no, I didn't ask about safety. Make sure you ask about safety. And then finally, now we're getting down into the more very micro level, which is symptomology. So assessing psychological factors and getting down to the actual symptoms. As I've explained before in class, the things that you want to look for, the aspects you want to look for with symptoms are the frequency, that's how often the symptoms occur, the duration, so how long are they lasting? Is it 1 day? Is it 2 weeks? Is it 6 months? What is the severity and intensity? Is it mild? Are they able to function still? It just impacts them mildly throughout the day. Is it moderately impacting them? Meaning, now it's really starting to impact relationships. It's impacting their job. It's impacting their functioning. Or is it severe? They're about to lose a relationship, lose a job, fail out of school. Are they at higher risk because of the symptoms? And then also the chronicity, meaning when was the onset of those symptoms? Was it yesterday? Was it 6 months ago? Was it 10 years ago? Understanding also periods of remission. So the term remission, I haven't used that in class much. We're not quite to the point of talking about the DSM and that, but remission are those periods where the symptoms are really no longer present anymore. So you may have clients that have had depression for several years, and then maybe they'll go through several months or maybe even a couple of years where it'll be in remission. The symptoms will not even be present. They'll be functioning okay. And then all of a sudden, they're back for some reason. So also calculating in and factoring in the timeline of remission. And then finally, one of the most important that hopefully you've learned in class, and if not, this in conceptualizing a case, even though we have all of this information, and that's why this is kind of listed last, or one of the last things is, let's say you have all of this information, you've done an amazing job on a biopsychosocial and on a systems level, and all the while this client is actually doing really pretty well. It's also important to assess the impact on functioning. So how do all of these factors impact this person's ability to function, both intrapersonally, so on an individual level, within families, relationships, socially, as they interact with other systems such as employment, school, other systems in the community. What is the impact on that functioning? So again, it's going from the micro and then asking yourself as a clinician when you're conceptualizing a case, how does this spill over into other systems that they interact with? As we develop a diagnosis in the summer course, when you take the DSM, that's going to be one of the key criteria is, no matter what the symptoms that they're going through, are those symptoms impacting their functioning across multiple areas, such as family, relationships, employment, schooling, whatever it may be. Being able to describe what that impact is on functioning and if there's any impairment being caused by those symptoms. Are they struggling in their job to concentrate or to work, be productive? Are they struggling in their relationship to have a functional relationship with their spouse or partner or with their children? Those are all things that you want to factor in when you're conceptualizing a case. So it's going from the large, the systems perspective, down to the micro, And once you get to the micro, it's then looking at kind of going back outwards and looking at how all of this is impacting functioning as a whole, as an entirety. Last thing, as far as conceptualizing a case, I wanted to include this, even though this is more so for the summer course in your advanced practice course. I wanted to include this here because as you're conceptualizing a case and sitting in front of a client, these are some of the things that you'll want to pay attention to. So for example, they call it a mental status exam. Now in psychology, a mental status exam is it's got a lot more elements than just observations, which is what this is. Mental status exam in psychology is a series of kind of mini tests that they ask clients to do, whether it's memorizing, whether it's having them finish a particular phrase. A psychologist, they do a lot more when it comes to mental status. For us as social workers, I'm just going to teach you what is very common in the field for us. And that, what we call a mental status exam, is just merely what we're observing with the client face to face with regard to their speech, which can be, maybe it's normal and their speech is fine. Maybe it's very rapid, maybe it's soft, maybe it's pressured. Then you're also looking at their mood. Are they sad? Are they anxious? Are they happy? Are they hostile and angry? Mood is an important one that you'll want to have a descriptor on. What's their affect? So affect is their facial expression. Is it appropriate? Are they crying when it's appropriate to cry? Are they laughing when it's appropriate to laugh? Or is their affect, which it says here, is it flat, meaning is it kind of emotionless? Is it incongruent, meaning are they laughing when they're talking about maybe the death of an individual, or about their trauma? Maybe they're laughing, so it's very incongruent with the situation. Then you're assessing all the while their motor activity. So are they pacing? Are they, having kind of, are they shaking? Are they having tremors? Are they restless? That's another thing that you're going to want to observe as far as what this individual is doing in front of you. Then perceptions. So is this person having any sort of hallucinations, whether it's visual, auditory, tactile, which is sensations, feelings, gustatory is taste, olfactory is smell, thought content, is this person having obsessions or phobias or some sort of persecutory fears? What's their thought process like? Are they perseverating on a particular topic and just will not let it go? Is their speech and process very tangential? They can't follow a particular line of thinking. Then we move on to consciousness. Are they alert? Do they seem confused, sedated? There's been times where I've definitely had clients where you can tell that they took their medication either too late, or when they came to their session, because of having it taken too late, they were kind of sedated. It was difficult to talk to them, and so that's part of a status exam, is kind of checking these boxes as far as how is the client presenting in front of you. Orientation's an interesting one. They say that first box, orientation times 4. Times 4 means, are they oriented to time, place, person, and situation or circumstance? So if a client's able to pretty much recognize what time it is, where they're at, who they are, and what the current situation is or circumstances, then it's called oriented by 4. Finally, you have memory, which for the most part is intact unless you have a person who's really struggling with memory. Maybe they have a poor memory or poor immediate memory. Attention issues. I've definitely had clients that have been very easily distractible. They're unable to attend to the conversation. They're very distracted with what's going on around them. Judgment. Now, in this particular list that I have here, it says mildly impaired or significantly impaired. I'll sometimes put fair, good, fair, poor. This is that, and this is very subjective. This is from you as a clinician. Do they have reasonable judgment? And base this a lot on kind of consequential thinking and ability to make reasonable judgments. Are they spending way too much? Are they impulsively spending? Are they, possibly going out and abusing, abusing substances or making, choices that way? Maybe you might subjectively say their judgment is fair or poor if you're finding that their behaviors really are lacking judgment. And then finally, insight. Does that person have insight into their behaviors? Or do they have poor insight? They don't think that they have an issue. They can't see the consequences of their behaviors. They can't think of potential consequences. These are all things that you'll want to consider with insight as well. So in conceptualizing a case, as I went through all of those other slides, you're talking about symptoms on an individual level. You're talking about systems impacting them. And then when they're sitting in front of you, you're also paying attention to these factors right here that I've listed, which for, once again, social work, we call this a mental status exam. If you were to tell this to a psychologist or a psychiatrist and say that, you did a mental status exam, they may chuckle and laugh at you and say, you don't know what you're talking about. That's not a mental status exam, which in some ways they're right. They have a very detailed mental status exam that does a whole bunch of different things, but for us, for reasons of clinical work, this is what we call a mental status exam, is our subjective observations of these areas there. And you'll want to do that. I usually do that on a session by session basis every time they come into the session, because obviously things change. So I make sure that I do one of these, or at least write down my observations each time. All right, that is the case conceptualization portion of this. So it's factoring all of that in, and now we're going to go on to talking about treatment planning here in the next video.